Welcome to the Scleroderma Association of BC's 38th Annual Conference. I'm Roseanne Queen, and I'm the president of SABC, and it's my pleasure to introduce Dr. Marie Hudson. Dr. Hudson is a rheumatologist and clinical scientist at the Jewish General Hospital and Lady Davis Institute, an associate professor and a member of the Division of Experimental Medicine at the Department of Medicine at McGill University. She pursues research in systemic sclerosis and is the founding member of the Canadian Scleroderma Research Group. Her particular research interests include interstitial lung disease, muscle involvement, and cellular therapies for scleroderma. Dr. Hudson's presentation is on the progress of cellular therapies for scleroderma. Dr. Hudson.
Thank you. So first of all, thank you very much for this very kind invitation. I have to start off by saying that the patient groups in scleroderma are very motivating. You give us a lot of reasons to want to do what we do. So thank you for everything you do. The other thing I just want to point out, in case there's anybody on the call this morning from Kamloops, is that I have a twin sister who's actually a rheumatologist in Kamloops. So there's actually two of us. I don't want to confuse anybody on this call. There's the East Coast Dr. Hudson, that's me, and on the West Coast Dr. Hudson, that's her. So, and if you have scleroderma and you see her, she's always texting me, what do I do, what do I do? So, yeah, I may have heard of you already. Okay, so I'm going to share my screen. Yeah, here we go. I'm going to put it in presentation mode. Okay, so this morning I'm going to talk to you about one of the fields of interest that I have in terms of research in scleroderma, and it has to do with cell therapies. And you might say, what do you mean by cell therapy? So what I'm talking about is actually using human cells to treat scleroderma, and I will talk to you and explain this to you carefully. So while we have medications, things like aspirin, things like Cellcept that are synthetic, and many of you have heard of these drugs. We also have biologics. Many biologics are produced, many of them are antibodies. Here we're actually using whole human cells to treat scleroderma. So let me walk you through what I mean by this. So I will see if I can, yeah, here we go. When I do official presentations, we're supposed to disclose some of our industry related funding. The reason we do that is to be very transparent, to make sure that you're aware that I may have some biases, but I must say that the funds that I have had from pharma in the last couple of years have not been used at all to support my work in cell therapies. So I'd like to think that this presentation is fairly unbiased, and I will be talking about off-label medication use. So there are many different types of human cells that can be used for various diseases, for various indications. In the field of scleroderma, we talk mostly about hematopoietic stem cells, and we talk about mesenchymal stromal cells. So these are the two cell types that I will be talking about and describing for the purposes of this talk. But as I say, there are other experimental types of cell therapies that are, around the corner, I would like to think. So just to give you an idea of a starting point. So what I'm showing you here is your femur, which is your thigh bone. And our bones are obviously important. They're our skeleton. They are what keep us upright. But our bones serve a very, very important function because in the bone marrow, our blood is produced in the bone marrow. And so if you take the high resolution look at what's going on in the bone marrow, there's all these cells in the bone marrow that are present and that give rise to what circulates in our blood. So the key cell is this small purple cell here. That's the stem cell, a hematopoietic stem cell. Hemato means blood. It's the stem cells of all other blood cells. So the way it works is you have this stem cell, and this stem cell can, in the bone marrow, differentiate to many, many other subsets of cells. some of the most commonly known types of blood cells that arise from the stem cells are actually our red blood cells. And the red blood cells are important in our body. They are what help circulate oxygen, allow us to breathe. And when our red blood cells are low, that's what we call anemia. The stem cell also produces our platelets. Many of you have probably heard about platelets, your platelets sometimes being high, sometimes being low. Platelets are important in terms of clotting. And then there's a whole slew of other cells that all arise from these stem cells, these hematopoietic stem cells. But what's particularly important in the setting of scleroderma is our lymphocytes, our white blood cells, also arise from these hematopoietic stem cells. So these are the cells that are produced in the bone marrow, all with the same stem cell generating all these differentiated cells. The other really important type of cell in the bone marrow is what is in green here. These are what we call the mesenchymal stromal cells. These cells, they were first identified in the bone marrow, support the stem cell. They nourish the stem cell. So in the setting of scleroderma, we talk of hematopoietic stem cell therapy. We're going to talk about this. But now we've come to understand that these supportive cells also have the potential to be used as cell therapies. And we will talk about mesenchymal stromal cell therapies. Okay, so these are the two cell types that we will be discussing. So the next point is, as I mentioned, one of the biggest problems in scleroderma is that the white blood cells, there are clones of white blood cells, some of the white blood cells, either T lymphocytes or B lymphocytes, that are at the root of the disease in scleroderma. That is why we say that scleroderma is an autoimmune disease. The disease probably starts in some of these T lymphocytes and B lymphocytes that have started to attack our own body. So normally the T lymphocytes and the B lymphocytes are really important, have two really important functions. They are there to protect us from infection, so from external agents. They are also there to protect us from cancer. And there's a lot of research into how we can use lymphocytes right now to treat cancer, but we won't talk about that today. What the most common function of these lymphocytes is to fight off infections. But in scleroderma, some clones, some subsets of these lymphocytes become diseased. And instead of just fighting off external agents, things like viruses or bacteria, they start to fight off some of our own tissues. They become self-reactive. And that's what we call is an autoimmune disease. So one of the key targets of treatment of scleroderma is how can we tame these abnormal lymphocytes and try to sort of get the disease under control. So and I don't want to be depressing, but why do we need good treatments for scleroderma? Just by way of background, this is a study that we did a few years ago with the Canadian Scleroderma Research Group and the Australian Research Group. We pooled our data together and we showed that in scleroderma, the risk of mortality at any point in time is about fourfold what it is for a person who doesn't have scleroderma. It's a deadly disease. Sometimes I say, it's just as bad as cancer. People don't like the C word, but scleroderma is a pretty scary word as well. And what we also showed in this paper, when we looked back at the literature over the last 60 years, we have not made a dent in this mortality. So we do have some treatments. Many of you, I'm sure, have been exposed to different drugs to tame the immune system. It does get the disease somewhat under control, but it doesn't really make a big impact in terms of the ultimate outcome, which is mortality. So it's a really serious disease. We need to get better treatments. The other thing, also another paper that we did subsequently, again with the Australians, is it's a deadly disease, but while you have the disease, you develop a lot of organ damage. There's a lot of, and this damage doesn't happen in 5 to 10 years. It used to be called progressive systemic sclerosis. We used to think that, oh, this is a disease that's just going to progress over 10, 20, 30 years. What our data shows is that the damage, whether it's in the skin, in the circulation, in the GI tract, it happens early. Within the first 2 years of disease, the majority of patients will have some irreversible damage. So clearly we need better treatments, and we need treatments that we should be using earlier. So the Europeans put together these guidelines in terms of reviewed all the potential treatments for scleroderma. These guidelines are available, but unfortunately, our treatment options, I would say, once you read these guidelines, most of the treatments we have right now for scleroderma are symptomatic, to relieve the Raynaud's, to relieve the heartburn, to relieve some of the symptoms, but they are not treatments that are targeted at the disease itself, to try to turn off the disease. And so that's where we need to start to think of some of these better treatments. So that brings me back here to our starting point. So because the disease is in the lymphocytes, many of the treatments that we've had so far is to try to use immunosuppressives, so medications that will turn down this hyperactive immune system. So the most common medications, many of you may have been exposed to these, are methotrexate. We used to use a lot of methotrexate. We're using a lot more Celcept or mycophenolate. Some people, if it's quite severe, we've even used cyclophosphamide. These are all immunosuppressants. But as I said, in the last 60 years, despite the fact that we've been using these drugs more and more, we really haven't made a lot of progress in terms of controlling the disease. So here comes this great idea that some hematologists had. So it wasn't rheumatologists, it was actually hematologists who said, well, if the disease is in these lymphocytes, maybe we could give some sort of chemotherapy, just as we would for cancer, eliminate all of these cells, and then allow the healthy stem cells to simply repopulate the whole blood cells, including a healthy immune system. So this is the rationale behind hematopoietic stem cell transplant. The hematopoietic stem cells are healthy. So if we can get rid of the unhealthy cells, then we allow the hematopoietic stem cells to repopulate a healthy immune system. How is this done? So there you go. So this is done. This is the process of a hematopoietic stem cell transplant. So the first part of this process is called mobilization. And the purpose of the mobilization is done with various drugs that will stimulate the release of the stem cells into the circulation. Okay, because the first thing we want to do is we want to be able to get somebody's stem cells and store them outside of their body. Okay, so that's called the mobilization. And I must here, I should point out, many of you have probably heard of bone marrow transplants. And the reason why there were bone marrow transplants, as I said, the stem cells are in the bone marrow. People would get the stem cells by doing a bone marrow biopsy, and from the fluid that they would get from the bone marrow biopsy, they would isolate the stem cells and put them away for future use. It is now much less invasive. We don't do bone marrow transplants anymore. We do mobilization from a peripheral vein by using this medication that's called GCSF that will cause the release of the stem cells into the circulation. And then this patient will then have an IV inserted in their arm, and the stem cells are going to be identified and taken out of their circulation and preserved. Okay, these are the healthy stem cells that we're going to put aside. Then comes the really difficult part of the process. Is now we give the person with scleroderma who's undergoing the transplant, we give this person very high dose chemotherapy. Okay, this is essentially treating scleroderma as it would be a cancer, with the idea that we are completely or almost completely eliminating all of the circulating cells in this person's body, including the unhealthy lymphocytes. So this is the serious part of the procedure, because for a while this person has no functioning red blood cells. They often need a lot of transfusions. They have no functioning platelets. They need transfusions as well. They certainly have no functioning immune cells, and therefore they are at very high risk of infections. While this person, and this is the aplastic phase, while the body oh, sorry, and I skipped an important part. So we give them chemotherapy. They're at very high risk of complication. But once we've eliminated all of their cells, we give them back their own stem cells, okay? And these stem cells have a way of finding their way back into this person's bone marrow. And within about 3 weeks, they will start to produce a healthy circulating blood system. They will start to produce red blood cells, platelets, and lymphocytes. Okay, so the stem cells here are healthy. They are taken out of the person before they undergo this high dose chemotherapy and preserved. Then the person's immune system is eliminated through high dose chemotherapy. Their own stem cells are given back to rescue the fact that they have now no more immune system. And it takes about 3 weeks and then a year or two, but essentially the really problematic period is the first 3 weeks for the person to start to produce their own cells from this stem cell. Okay, so that is the procedure. So what do we know about stem cell therapy for scleroderma? So we have only 2 trials, 2 fairly good trials, but nonetheless, one trial treated 79 patients with scleroderma patients with stem cell therapy, and the other trial 36 with stem cell therapy. So that means that right now we're offering this procedure to patients on the basis of 2 fairly small experiments with about 110 patients in total. That is not a lot of data compared to, if you want to think about in the cardiovascular trials where they look at all sorts of new therapies, and they have 10,000 patients on which to, generate evidence and offer treatments to patients. But nonetheless, because this is a rare disease and because this is a fairly toxic procedure, these trials don't come by very often. So ASTIS was done in Europe. There were 29 centers in Europe. The SCOT trial was done in the US with 25 centers in the US. Both started in the early 2000s. Both were randomized. So patients were either randomized to stem cell transplant or to 12 months of cyclophosphamide. But this was open label. You can imagine that you can't do this in a blinded fashion. People know whether you're getting a stem cell or a transplant or not. And the data in the ASTIS study goes out to 7 years and about 6 years in the SCOT trial. The other really, really important difference between these 2 procedures, and it is an issue, and I can tell you in Canada, our practice is changing, is that they didn't use exactly the same conditioning regimen. So that's the high dose chemotherapy that these patients get. ASTIS tried to give a lower dose, thinking that we're trying to eliminate the immune system, but we don't want to make the patients too sick because then the risks of infections are higher. While SCOT actually gave what we call myeloablative doses, so very high doses of chemotherapy, and they also added total body irradiation, so X-ray therapy to the whole body to try to completely eliminate the person's immune system, okay? And I can tell you that for a long time, I've been referring my patients to Ottawa and they've been doing non-myeloablative, but in Calgary, I'm pretty sure that they've been doing myeloablative transplants for these past many years. And there's debate about whether one or the other is better, but there are definitely differences depending on where you go for your transplant. Does it work? Well, that's the data from, on the left, the data from the European trial, and on the right from the American trial. And for the first time, this is the only treatment, and I would say this is the best treatment for scleroderma, where we see that the treatment actually prolongs life, that there's a survival benefit to transplant over conventional treatment, which is cyclophosphamide. So what these curves show you is that the transplant arm is on the top, and the cyclo arm is on the bottom. What that means is that the patients who have transplant live longer than the patients who get just conventional therapy. And this was exactly the same thing in the American trial, where the transplant arm is in red. And so because it's on top of the blue line, which is the cyclophosphamide arm, it suggests that the transplant patients live longer. So yes, everybody's pretty convinced that there is a survival benefit with transplant. As I said, those two trials represent really about 110 patients. That's not a lot of evidence, but there have been other people who have been looking at transplant for scleroderma for many years. So what we did with one of my master's students, she's just about to finish her master's student project, is we said, okay, we have two positive trials, but what does the rest of the studies in the literature tell us? Is the data really concordant, or are there other things that we should be thinking about when we look at scleroderma, transplant for scleroderma? So she did what we call a systematic review of the literature. It's a really formal process where you go through the literature and you try to collect all of the relevant information. And she actually found, in addition to the two top trials, I'm trying to move this here, which I mentioned already. So the American trial is on top, the European trial is the second one. She found 10 other studies of a transplant for scleroderma. And if you sort of add up these numbers, this comes out to about, I counted it this morning, 539 patients. So in the literature, there are reports of 539 scleroderma patients who have been transplanted. So we have a little bit more evidence in terms of the role of transplant in scleroderma. And so when we look at all of this data together, so that's what we do in a systematic review, what do we find? So she sort of pooled the data, and here the orange line represents the patients who get transplanted, and the yellow line, the patients who get conventional care. And again, out to 2, 3, 4 years, again, very consistent with the two trials, transplant is associated with a survival benefit in scleroderma. But there's this point here at the beginning where actually the lines cross. And this gets people, this point where things cross gets people really, really worried. Why does it suggest that actually the transplant patients do worse at the beginning and then better over time? Okay, and this is where the catch with transplant is. Here I keep insisting that people do better over time, but the problem with transplant, because there's such high dose chemotherapy that's given with for the purposes of the transplant, is that there's huge treatment-related toxicity. Okay, that the chemotherapy, not the disease, not the scleroderma, the treatment is very toxic and can be associated with what we usually say a 5 to 10% treatment-related mortality. So when I try to say this in plain English to my patients, usually we offer transplants to the sickest of our sick scleroderma patients. Okay, and when I have the sickest of my sick scleroderma patient, I usually say your 5-year survival is about 50%. So that means that in the next 5 years, you have 50% chances that you're not going to make it to beyond 5 years. That's the reality. But if you go for transplant, right there from the treatment, you have about a 10% probability of death just from the transplant. So you're switching a poor 5-year survival. And often when I do this, and these are young people, they say, well, maybe I'm going to be sick for 5 years, but I'm going to be sick and I'm going to be around my kids for 5 years. Whereas if I go for this procedure, and yes, the long-term benefits are really promising, but there's a 10% chance that I won't see my kids beyond the next year. Okay, so that's the catch with scleroderma, is that it's the best treatment, and with the transplant, it's the best treatment we have, but it's also the most toxic treatment we have. And the weighing the risks and the benefits are really something that is really individual dependent. I have had some patients look me in the eye and said, this is really not for me. I can't, take the risk of this 10% risk of treatment-related mortality. And I've had other people, again, recently, a young woman who said, with young children, who said, I want to do everything I can. And so these are the people that we work up and we walk them towards transplant. So that's the toxicity of it. So over time, what have we seen in terms of uptake of stem cell transplant for scleroderma? So scleroderma here is represented in green, and the graph below is a timeline. The x-axis are years, and over time you can see that the green section of the bar graph has increased. So the use of stem cell transplant for scleroderma has really increased quite a bit, but it's pretty much stalling at this point, which suggests that we are using it, but we understand that there are limitations to this procedure. It's not going to be, definitely not going to be for every scleroderma patient. Okay. The other thing, and again with my master's student, and we published this a couple of years ago, there's so much emphasis in terms of survival. So with transplant is associated with the survival benefit. But the question we ask is, it's one thing to survive, but how do our patients feel? Do they actually feel good when they survive? Or maybe they are just as sick as other scleroderma patients, and we expose them to the toxicities without necessarily making them feel better. So the way we approached this question, we were lucky enough, and are still lucky enough, to be collaborating with some experts in France, in Paris, who have a lot more experience. The person is Dominique Fache. She has led the ASTIS trial. So already in the years 2000 in Europe, they were really much more aggressive in terms of using transplant for scleroderma. So we decided to collaborate with her. And as mentioned, we have this large Canadian cohort of scleroderma patients with a denominator here. It says 1,500, but I think we're closer to 1,700 so far. And what we did is she provided us with data of 41 of her transplant patients. And we looked in our scleroderma cohort at patients who could have met criteria for transplant. They could have gone for transplant, but because in Canada we're just not there yet, they got usual care. And so we decided to compare the transplanted patients in France with the very sick scleroderma patients in Canada. And we compared them to see how they feel and function in addition to surviving. Okay. So of course, the first thing we did, we looked at, did our data look like the trial data in terms of survival? It looks exactly like the trial data. So again, the transplanted patients are in red, the red line above, the patients treated with, so these are all in red, the French patients who underwent transplant. And here in blue are all Canadian patients who could have met criteria for transplant, but because it's not routine in Canada, they were treated with things like cyclophosphamide, mycophenolate, methotrexate, the usual oral drugs that we've been using. So definitely, the first thing that is clear from this graph is that the French patients live longer. But do they feel better? And that was the question of this study. And so to answer that, we looked at 3 different ways of how do patients feel. So we have, and many of you, if you've participated in research studies, have probably filled out what is called the Health Assessment Questionnaire, the HAQ. The HAQ really measures a person's function. And the HAQ, you ask the walking, hygiene, eating, all different aspects of daily life. We ask them, can you do this with no difficulty, a little difficulty, some difficulty, or a lot of difficulty? So every question is rated from 0 to 3, 3 being bad, okay, because it means that you're doing inactivity with a lot of difficulty. So anything that's closer to 3, the patient's function is poor. Anything closer to 0, the patient's function is better. And what the data on the right here shows is that on average, the French patient's function was anywhere from 0.5 points to almost 1 point lower than the Canadian patient. So what does this tell us? Not only do they survive better, I just showed you that, but their function is hugely better than our patients on average. Differences of 1 point on the HAQ scale is a huge, really clinically meaningful difference in functioning. So yes, the patients function better on that one instrument. We also looked with the HAQ, there are some symptom scales, and we asked patients on a scale of 0 to 10, tell us about your pain, tell us about your Raynaud's, tell us about your ulcers, tell us about your GI symptoms, dyspnea, and overall how you feel. Again, because it's a 0 to 10, anything that's closer to 0 is normal, and anything that's closer to 10 is very, very poor, okay? And again, because the numbers are in the negative range here, it suggests that the French patients overall on all of these symptoms are doing much better than the Canadian patients. So the transplanted patients have much less pain, and these numbers are huge. When we talk numbers of -2 to -4, if you just look overall, we ask them on a scale of 0 to 10, how are you feeling? On average, the French patients were 3 to 4 points lower than the Canadian patients. So let's say on a scale of 0 to 10, you can ask yourself, how do you feel overall? And you would say, well, I'm probably with my scleroderma, maybe I'm a 6. Well, on average, the scleroderma patients who've been transplanted are a 3. Okay, so there's huge differences in the way that their symptoms behave. And you might even ask, does this make sense? How can transplant actually help with digital ulcers? Because transplant is really directed at the immune system. But I was looking, and I think it's my last slide here. My next slide. This paper actually came out yesterday, and this is a paper of patients who underwent transplant, and they did their video capillaroscopy to look at their circulation, and the circulation is what's really problematic in terms of Raynaud. The circulation is what's really problematic in terms of the digital ulcers, and they looked at the circulation, and here, this person, this is done at the nail fold, and at this section of the nail fold, this person has no circulation. So clearly pre-transplant, there's a lot of vascular abnormalities. And then they looked at their patients post-transplant, and there's a whole lot of new blood vessels there. So it's, the science in terms of trying to understand why a therapy directed at the immune system will benefit the vascular system. There's a lot of work to try to understand why that happens, but it clearly happens, okay? So transplant is going to be beneficial, not just at the immune manifestations of scleroderma, but at the vascular manifestations as well, okay? And then finally, so I said we looked at the HAQ, we looked at the symptoms, and the last thing we looked at in our patients to see if post-transplant they feel or function better, we looked at a measure of quality of life. The measure is called the SF-36. It's a questionnaire with 36 questions. It's probably the most widely used questionnaire in the world to measure quality of life. And we measured the quality of life in the French patients who'd been transplanted, and we compared it with the quality of life of our Canadian patients who were not. And again, without getting into the details of these numbers, the French patients measured their quality of life much, much better. So usually a difference of 5 points would be a big difference, a meaningful difference in terms of quality of life. And here, what I'm showing you is that the French patients have a quality of life on a scale of 0 to 50 that's 10 points and even 18 points better than the Canadian patient. What I also point out, though, is that when we use the SF-36, we can look at what we call the physical component of quality of life. That's your physical functioning. And those are the really excellent numbers that we see that are associated with transplant. But we can also measure what we call the mental component of quality of life. And what was striking to us is while our patients physically are doing, while the transplanted patients are doing much better from a physical point of view, there was really no difference in terms of the mental related quality of life. And so that was very perplexing to us. And we've thought about this data very long and hard, and there are probably many explanations for that. But having seen many patients now who have undergone transplant is not curative. So post-transplant, patients still have hand contractures. They still have some rainbows. If they had lung disease before their transplant, that's not reversible. It doesn't progress as much, but it's not reversible. And therefore, yes, there is a lot of physical improvement related to transplant, but the patients still have scleroderma. So whether you had scleroderma before transplant and you still have scleroderma after transplant, all of the mental health related aspects of the disease are still there post transplant. And that's really very important to tell to our patients, because it's really important to help our patients manage their expectations. Many people really insist on the benefits of transplant, the survival benefits. But the fact is, after transplant, you still have scleroderma. It's not a cure. So don't be disappointed if your finger contractures don't go away. So it's really important that patients go in there with being very well informed about what to expect post-transplant. So basically, that's the summary for hematopoietic stem cell transplant. So there's definitely better survival, and definitely from our data, really associated with the improvements in how patients feel and function. There's no improvement in terms of mental health related quality of life. And what really limits the procedure is this the high toxicity, the treatment-related toxicities, which means that this is not for everybody. In fact, if you think back at the numbers that I showed you, in this Canadian Scleroderma Research Group, there's about 1,500 patients, if you want. Only 85 of those, so that's less than 5%, would have met transplant criteria. So when we talk about transplant is for a very, very highly selected group of patients, less than 5% of scleroderma patients. So, and even among those, not everybody is willing to undergo transplant. So it's not going to be the solution for the vast majority of patients. So that's why we need alternative treatments. So that brings me to the second type of cell that I'm going to talk about. So I finished the first part talking about stem cell transplant. And now we're going to talk about these green cells, so these stromal cells that were identified, and that initially were identified in the bone marrow, and were thought to be very, very important to play a supportive role to support the stem cells. Okay, so that's what I'm showing you here. These are the mesenchymal stromal cells. They were initially identified as having the supportive properties for stem cells. But then over time, there's been a lot of research on these cells in a lot of other disease settings. And what they've also been shown to have, they are antifibrotic, they are pro-angiogenic, and they are also immunomodulatory. And so these are actually the three pathogenic processes in scleroderma. In scleroderma, there's too much fibrosis, there's not enough of angiopathy, that's why we have the vascular problems, and there's too much inflammation. And so over time, people have started to look at whether these MSCs themselves could be therapeutic cells for scleroderma. And so so initially, as I mentioned, they were identified in the bone marrow, but these MSCs have now been identified in many, many other tissues, okay? And the three most common sources of MSCs are the bone marrow, because that's where they were initially identified. But to get them out of the bone marrow is a very invasive procedure. Undergoing a bone marrow biopsy is really unpleasant if anybody has ever had one. They can come from adipose tissue, that's fat. But again, we can get adipose-derived MSCs through liposuction. So it's not a benign procedure. Or they can come from umbilical cord. And in the umbilical cord, and this we consider as a non-invasive source of MSCs, because umbilical cords are usually discarded. And the way I describe it is, in the umbilical cord connects a mother, one human being, to a baby, which is a different human being. And the blood flows back and forth from the mother to the baby. So normally you would think that the mother would reject the baby, or the baby would reject the mother, because they're just two different bodies. But all this blood goes through this umbilical cord, which is loaded with these immunomodulatory cells that say, calm down, don't get super activated, and it allows the mother to bear the baby for 9 months. And so if you look at the properties of these MSCs in the lab. They are immunomodulatory. I didn't show that to you, but what I'm showing you here again, and this is work from one of our master's students, they are antifibrotic, definitely in the lab, they are antifibrotic, so keep that in mind. And again, another one of our master student was looking at whether they could help grow blood vessels. So if you just look at this panel here, on this panel here, these are just random vascular cells, random cells that make up the circulation. And if over these random cells, you add on these umbilical derived MSCs, you can see all the little green spots here is the beginning of a formation of a blood vessel. So clearly in the lab, these cells clearly have the potential to form new blood vessels, which is something that would be really exciting for scleroderma. So the idea is if we can get MSCs from one of the various sources, in particular the umbilical cord, if they have different properties that could potentially be beneficial for scleroderma, modulate the immune system, grow new blood vessels, be antifibrotic, then perhaps they could be therapeutic for scleroderma. And so far, there's been only one study done in scleroderma patients, and it was published earlier this year. And this was using bone marrow derived MSCs, so a very invasive procedure. And what they did is they only gave one infusion of the MSCs. And the data I'm showing you on the right panel, first of all, on the top is the skin scores of these patients. So in the lab, the cells seem to be antifibrotic, but in humans as well, there's a suggestion that the skin scores fall and stay low over 1 year. So that's very exciting to think that there would be something that could help reverse the fibrosis at the level of the skin. And the bottom panel shows you the lung function of the patients who were in the study. And while we think that most scleroderma patients lose lung function over time because there is some fibrosis in the lungs, in these patients over about, I think, 12 months, the lung function remained stable. So it didn't improve, but at least it remained stable. So this is the first signal that these cells might be therapeutic for scleroderma. And that brings me to the last section here, where based on these promising data, we have now been funded by the Canadian Institutes of Health Research, which is a federal government funding body, to do a trial of umbilical cord derived MSCs. So while the French study that I just showed you used bone marrow derived MSCs, which was quite invasive, we are going to be using cells that have been collected in an umbilical cord that was otherwise going to be discarded. And the other thing that we're innovating in this trial, so not only is the source of the cells different than the French trial, but the French trial only gave one infusion. And we're curious to see if you give a second infusion, could you not have even more effect in terms of the fibrosis in scleroderma? So our two main outcomes are going to be, first of all, we need to make sure that these cells are safe in scleroderma, but I'm quite confident that they are, because they haven't been used just for scleroderma. They've been used for Crohn's disease, for multiple sclerosis. They've been used for COVID. And so generally they are felt to be relatively safe, but we still need to prove that. But the second thing is we're really curious to see what we'll have and what kind of impact we're going to have on the skin of our patients. And of course, we'll be looking at multiple other organs, but the primary efficacy outcome will be the skin scores. So this was last week, I think I got permission from Health Canada to proceed with the trial. So this is very, very exciting when you get what is called a no objection letter, which means that Health Canada says you're allowed to start. So we're in the process of, this is our study startup. I'd like to think that we will probably randomize our first patient in January. It'll take us about a year or 18 months to randomize all 18 patients, the way the trial has been set up. And hopefully we'll have some data within about 24 to 36 months then I can come back and tell you what we found. So basically, these are my conclusions. So stem cell transplant is the best treatment we have for scleroderma, but it's really toxic. So it's not for everybody, and perhaps less than 5% of our patients are eligible for this intervention. So we need better therapies. And so I think that perhaps mesenchymal stromal cells, with the French study that was published this year, some of the lab work that we've done to demonstrate that they are effective in the lab, I think that there's exciting times to find some new therapies for this really debilitating disease. So I think that's it. So I will be happy to take questions.
Me myself here. Thank you very much for that informative presentation as well. Obviously, a lot of work going on, and from what I see as well, and that it takes a long time, for the results on that. We all want to cure right away of that, but all of these steps and all that make, they all help to move forward on. So we do have a couple questions here. How would a patient pursue either of these treatments, stem cell transplant or MSC? Do you know of a facility where these options are available for patients from BC?
Okay, so we'll talk about stem cell transplant first, because that is currently a therapeutic option that's available. Most places that do for hematologists will do lots of transplants in most hospitals, okay? But for autoimmune disease, for hematological problems, leukemias and multiple myeloma, that sort of thing. So transplants are fairly accessible. The tricky part is doing transplant for autoimmune diseases, and in particular for scleroderma, is another level of complexity. The hematologist knows everything about hematology, but they don't know a lot about rheumatology. And ideally, you want to go where there's a hematologist who's familiar with transplant, but a rheumatologist who's familiar with the transplant as well. It's been well shown that the sites that have these the outcomes of patients at sites with multidisciplinary teams are better than the outcomes of patients who go to sites that don't do very many transplants and who don't have rheumatologists or whatever. So right now in Canada, when I discuss a stem cell transplant with a patient, I say there are two expert centers. There's probably in Vancouver that it could be done, and in Montreal it can be done, but the two expert centers are really Calgary and Ottawa. And I try to direct my patients to Ottawa, and I think I'm pretty sure some of my colleagues out west usually direct their patients to Calgary. You really want to go to these expert centers that have seen this and that have been doing this for quite some time. That's what you're in better hands if you do that than if you decide to go at a site where the hematologist has a lot less experience. So that's for the stem cell transplant. For the mesenchymal stromal cells, that's still very experimental. These are not accessible to patients right now outside of this randomized trial.
Thank you. The next question. I've had systemic scleroderma for over 14 years. I have severe contractures of the fingers, limbs, and body. I cannot leave the house on my own, and I have to move about the house with a rollator. Have no balance. Cannot bend or straighten. I've been told stem cell would not help in reversal of my situation.
Okay, well, these are all difficult questions. So first of all, after stem cell transplant is probably no longer an option, because we tend to want to transplant patients early. And by early, we tend to say within the first 7 years. Okay, so usually because after that, we think that the disease is just so fibrotic that we're exposing the person more to all the risks of the procedure with very little benefit. Okay. Having said that, though, I have a couple of patients, and I have one of my absolute favorite patients. The first time I met him, he was a young man, about 35 years old. He came into my office. He'd had scleroderma for about a year. He had very bad contractures of the hand, such bad contractures of all of his joints, but in particular of his knees. He walked in with 2 canes. He couldn't stand straight. And because we thought that his disease was progressing so fast, he was quickly directed to transplant, and his contractures have all resolved. So he walks like a tall, straight 35-year-old man right now. So I somewhat disagree that the contractures don't improve. I have seen them improve with transplant. But he was somebody early on in the course of his disease.
And you may have mentioned this before, but what was the typical kind of the average age
Yeah.
in the studies?
So again, really tricky. All these inclusion-exclusion criteria are a moving target, but usually most of the studies, I think, that would not accept patients beyond the age of 60, but that's for the studies, okay? When I've directed some patients to Dr. Atkins in Ottawa, because he is such an expert, he can make expert decisions, you know, and if the person is 62, to him, that's not the end of the discussion. He keeps in mind that the person is 62, but then he's more interested in knowing, you know, how functional they were, how healthy they were in terms of their heart, their kidneys, and so on. So for the purposes of the study, there were hard age cutoffs. In practice, if you are otherwise well and 62, 63, I think that there's a little bit of leeway in the hands of an expert hematologist.
All right, thank you. Another question: was it easy to get patients for the MSc research?
So I haven't started. I think I'm going to get recruitment, but I say this is my little blue book here. I have many patients who want to sign up. Yes, I don't. I'll tell you why. First of all, because I'm speaking to very knowledgeable people here. You know your disease very well. Scleroderma patients are very motivated. You're motivated in terms of because you want to get better, right? And our treatment options are limited. So the scleroderma patients are motivated. And the second thing is MSCs are really safe. So you put together a motivated population of people with a fairly safe experimental therapy. It's still experimental, but it's a safe experimental therapy. And so I think a lot of patients would like to be part of this study, yes.
Okay. All right. One last question here right now is, how is your research funded?
Okay, so most of my, so the trial, I'll speak to the MSc trial, it's complicated, but the trial, we were very lucky. We were funded by the CIHR, which is like really, I don't want to use the word prestigious, but I think it's a huge recognition of the importance of this work. Okay, so CIHR funded, but getting CIHR funding, they never fund you completely for the whole trial. So we asked, I think, you know, I'll be transparent. We asked for $500,000 to do the trial, and they said, okay, we'll give you $400,000. Yeah, but my budget is still $500,000, right? So where do I get this extra $100,000? Plus, we've had a lot of trouble in terms of securing our cells. And in fact, just to transport my cells for the trial, it's going to cost me an extra $100,000. So I haven't even started the trial, and I'm $200,000 short. So where do I get this money? Well, I've been very privileged to get it from Scleroderma Québec. And so that's where patient associations like yours make a huge difference, because yes, we can get federal funding, but the federal funding is never enough. And so, you know, I turned around and I went to see Gaëtan Barry in Quebec, and I said, Gaëtan, I'm ready to go. I have $400,000, but I'm not going to be able to bring this trial to completion without some extra help. So essentially the trial is CIHR and Scleroderma Québec.
Right. Thank you. And I think that is all the questions that we have right now. Thank you again.
Thank you.
That was really informative, Dr. Hudson. Sorry about that. You had mentioned that we're pretty committed and really positive. Well, we really appreciate people like you that are doing the research, that do want to help us, and you're as committed as we are in helping you and helping ourselves. So thank you so much for your time. We really appreciate it.
Thank you.